So good morning. Got it. Thank you, Ryan. Good morning, good afternoon, or good evening, depending on where you are. So for those of you who don't know me, I'm Michael Hunt. I'm a professor in the Department of Physical Therapy at University of British Columbia in Vancouver, Canada. I am presenting or facilitating today from my office on the Point Grey campus, which is the traditional ancestral and unceded territory of the Musqueam people. And recognizing that many of you are coming from across Canada and across the world, just please take the opportunity to reflect on the cultural significance of the land that you're on. So this is event number 2 of our 2021 GaitNET-OA Canada Networking Series. We're hoping to do these with my co-director Cheryl Kozey from Dalhousie University, probably 2 or 3 times a year, plus or minus any sort of MSK Rehab Network Symposium conference. And for those of you who aren't familiar with the Canadian MSK Rehab Research Network, it's a very large national collaboration of researchers, clinicians, and patient partners looking at MSK rehab in general. And one part of that overall network is what we call GaitNET-OA Canada. And we've got about 50. We're slowly growing. We're always looking for more members. And really the aim of what we're trying to do is to improve clinical management of people with musculoskeletal impairments. And our value add is through enhanced collaborative research in the area of clinical biomechanics. We're mainly focusing on knee osteoarthritis for now. That's kind of the group that's come together. But the hope, of course, is that we can expand to upper limb, to back pain, using this collaborative model, which is somewhat unique to biomechanics research. So I don't want to take up any more of your time. I've got more important people to talk this morning. So it is a relatively informal plan this morning. We've got 2 speakers, Drs. Maly and Katherine Boyer, and they're going to set the stage, providing an overview of some of the mechanisms, some of the relationships between biomechanics and pain during movement, some things to think about when we're conducting research. And then we'll have a panel discussion. We'll have Drs. Tuhina Neogi, Lisa Carlesso, and Timothy Wideman, sorry, Tim. We'll be joining Monica and Katherine for about a 45-minute panel discussion. We'll see how that goes. And thank you to those of you who have already put some questions, and those questions will be asked to the panel during the panel session. And really, while we're listening to the presentations and while we're listening to the panel discussion this morning, 2 questions that I want you to keep in mind. One is, what do I need to know to improve my own research, and how can I take some of the things that are being discussed and change or enhance or modify the research that you're conducting? And then again, thinking about the bigger picture, what would we need to consider when building out collaborative network research questions? So part of the goal of GaitNET-OA Canada is to provide a platform, provide a mechanism for multi-centered national or international research, either multi-centered clinical trials or multi-centered cohorts, using pain, using biomechanics, maybe using imaging, and what are some of the things that we should consider that we haven't really discussed yet. And so part of the goal of this morning is to kind of set the stage for what we want to do and how to best answer some of these questions moving forward. So without further ado, I'm going to turn it over to, I just have to close this and show, thank you. Our first 2 speakers, and what I'll get people to do is we'll hold the questions until both presenters have finished, and then we can have a more thorough discussion. If you're not one of the speakers, please ensure that your microphone is turned off and your video is turned off, so that we can keep things moving smoothly. So our first speaker is Dr. Monica Maly. Monica is a physiotherapist and associate professor at the University of Waterloo. Her research focuses on developing biomechanically sound physical activity guidelines for adults with the most common forms of arthritis that are associated with aging. She uses biomechanical methods to evaluate the impact of physical activity on joint health, with the ultimate aim of developing guidelines for physical activity that promote health and productivity, while also minimizing the risk for OA arthritis progression. Many of you know Monica. She's led a number of studies that have integrated pain and imaging outcomes with biomechanical data, really looking at ways to better understand pathomechanisms of OA and effects of biomechanical abnormalities. Dr. Maly, I'll turn it over to you.
Wow, thanks. So you can see a screen and you can hear me? Sounds good.
Looks great. Thanks.
Great. Thanks. Well, thanks so much to Dr. Hunt and to Dr. Kozey for inviting me. Thanks for the kind introduction. And I'm so pleased to have this opportunity to share with everyone, and really honored to participate in today's session. So my goal today is to cover the background material that will hopefully set up Dr. Boyer's presentation as well as our panel discussion. And to that end, I've split our this presentation into 4 sections. First, I'll talk about motivation, and then I'll review some of the existing evidence around the associations between knee loading and pain. After that, I'll talk a little bit about some of the reasons underlying why we see the findings that we do. And then my hope is my key messages are going to lead directly into Dr. Boyer's presentation and our panel discussion. Now, for this group, it's no surprise to anyone that in knee osteoarthritis, our primary concern is pain. So as biomechanists, we need to bring this to our focus. And while we acknowledge there is a discordance between structural problems that we see inside the joint and the pain experience people have, ultimately it's pain that interferes with the people's lives and drives them to seek healthcare. When they do seek healthcare, clinical practice guidelines are really clear that we need to access education, exercise, weight loss, and if necessary, analgesia. And you could argue that there's a role for biomechanics in many, if not all of these core treatments. And one day we might envision a biomechanical treatment making it into this core set of recommendations. But further evidence that pain needs to be top of mind for biomechanists comes from Omeract Orsi. They've identified a set of outcomes required for clinical trials, and it states that pain is that first mandatory outcome when we're evaluating treatment. And so what I hope to do today is provide confidence that pain and biomechanics are intertwined. And for this reason, biomechanics has the potential to improve our ability to treat pain and should be monitored when we're evaluating treatments and treatment efficacy. So let's see if I can convince you. To get started, I'm going to provide a really basic schematic of pain signaling from an osteoarthritic knee. And I'll start by saying that by the end of this presentation, I hope that we'll put this little piece of the puzzle in its place. On the left, you'll see a knee that's signaling either the potential for or actual damage to some knee structure. In teal, I've tried my best to draw a little nociceptor. Let's pretend this is a free nerve ending. And its job is to carry that pain signal to the CNS. And its job really is to warn the human. It's to warn the human that something bad is happening to the knee, to inspire that human to change. So this pain signal serves a purpose to ask us to seek help or to avoid the exposure that we're currently engaged in. Now, traditionally, as biomechanists, we contend that it's loading exposures that cause knee damage and therefore initiate this pain signal. And by loading, please note that this could reflect just a whole gaggle of variables: joint contact forces, moments around the knee, muscle activations, cumulative load. That list could go on. But today I'm going to focus on the knee adduction moment, or the CAM. And the reason I'm focusing here is twofold. First, just for time, and second, because of the emphasis in the existing literature. But I do know that Dr. Boyer is going to expand beyond the CAM in her talk. So we'll just set a little foundation here. So when we're looking at the relationship between the CAM and pain, 2 kinds of evidence come up. The first is cross-sectional and the second is experimental. So I'm going to get started with the cross-sectional. And within this, within this cross-sectional work, the first set of studies involves comparison between people with and without pain, symptomatic and asymptomatic NEOA. And among this group of studies, they consistently show us that people who have pain have higher CAMs. I've given two examples here. The first one on the left is from an older study where they have plotted the peak knee adduction moment on the vertical axis. And on the horizontal axis, we see three groups. On the left, we have our symptomatic group with knee osteoarthritis. In the middle, we have a group with knee osteoarthritis, but no pain. And on the right, we have healthy knees. And what you'll note is the peak CAM is higher in the painful group compared to the two groups that have no pain, although I will admit that those box plots show a lot of variance there. On the right, we see some more recent work from Dr. Astefan Wilson, who used principal components analysis as well as some traditional techniques to compare asymptomatic with symptomatic people, all of whom had NEOA. So on the right, you'll see the gait, you'll see the stance phase of gait plotted along the horizontal axis, and on the vertical axis, the magnitude of the adduction moment. In black, you'll see a line for the mean of people with NEOA but no symptoms. In the dashed line, however, you'll see people who have NEOA with pain, and you'll note that the CAM is indeed higher in those who have pain compared to those who don't. The next set of cross-sectional studies is much more of a mixed bag, though. Here we're looking at studies that evaluated the association of CAM with pain. Now, do note that pain across these studies is measured with different tools, and CAM measurements come from, they're different CAM measurements from that waveform. And what you'll see on the left is a group of 3 studies found a weak positive relationship where higher CAM was associated with greater pain intensity. In the middle is a study that found no relationship between these variables, and on the right, a negative relationship. So a study that found a weak negative relationship where higher pain was associated with a lower CAM. Now, this last study might seem counterintuitive, but I'm going to ask you to hold that thought. Compiling these findings is not very compelling, is it? Not only do we have inconsistency between studies, we have weak relationships, if any, and the sample sizes are pretty small here. They range, well, relatively small. They range from 38 to 62. And across these studies, we do have confounders like footwear, gait, speed, medication use. So it's really hard to draw conclusions from this group. The next set, though, is more compelling. And these are experimental studies. These experimental studies manipulated pain and observed the effect of that pain manipulation on gait biomechanics. And today I'm just going to start with one example, and I know Dr. Boyer is going to show us some really cool work using this type of within participant design. So in this example, we have 34 healthy people who were tested on 3 different days. And on each of those days, their gait was assessed before and after an injection into their infrapatellar fat pad. And these injections were either painful with a hypertonic saline solution, or they were control. And there were actually 2 controls. You'll see one control was an injection of isotonic saline, and the other control was a sham. So they inserted the needle but didn't inject anything. And on the vertical axis here, you'll see the magnitude of the first peak of the CAM. Along the horizontal axis, we have time, and 5 minutes was the time point that they expected a lot of pain in that painful condition. And what you'll see is that during pain, CAM decreased. During pain, CAM decreased. So pain changed the mechanics, not the other way around. What if we do the opposite? What if we offer pain relief instead? So there was an older series of studies that used a variety of approaches to analgesia. They included NSAIDs, acetaminophen, or an injection of glucocorticoids, and all produce the same trend. If we provide analgesia and we reduce pain, we see the CAM increase. So to highlight this point, I've picked out one of these studies. It's a study of 53 people who had painful radiographic knee OA, and all of them agreed to a 2-week washout period where they stopped taking all of their pain medication. And during that washout period, their gait was assessed. Afterwards, they were randomized to receive either an NSAID, acetaminophen, or a placebo for 2 weeks, and their gait was evaluated once again. Now, the vertical axis here depicts the change observed in the CAM between the washout and the follow-up time point. Along the x-axis, the horizontal axis, we see change in pain. So you can see some people had no change in pain, while others experienced a decrease, and some people actually had an increase in pain. So here's that negative relationship again. People who had an increase in pain actually demonstrated lower CAMs. So it appears in knee OA, pain can modulate that loading environment. And it makes you wonder, were we looking at the picture backwards? Is this cause and effect approach too narrow? It certainly seems to be. We also see a mixed picture with weak relationships in our cross-sectional studies, and the strength of the relationships are not great. So the clinical relevance here is a little bit unclear. Why? Why is it that we don't see a tight relationship? Among many potential reasons, I'm just going to summarize 2. The first is that there are other variables that influence the relationship between CAM and pain. Some of them might be moderators. They might affect the strength of the relationship. Some might mediate the relationship or be an underlying mechanism. And some might actually be confounders that make it seem like CAM and pain are related when they're not. The second reason is pain and a perception, and I'm going to end there purposefully because it's such an important message for our group. But first, let's talk about other variables. And we know that at least one other variable influences the relationship between CAM and pain, and that variable is disease severity. Here we see data from 137 people with medial knee OA, and on the vertical axis, we have peak CAM. On the horizontal axis, we have pain, and we see these data split into 2 groups. There is a less severe group, a group with KL scores 2 or less, and they're depicted with open circles and a solid line. And we have a severe group in triangles with a dashed line. And you can clearly see the relationship between CAM and pain varies depending on severity. Now, this work has been repeated by another group in Australia, and I've tried to summarize the data here. And while we don't see concordance between the 2 studies, we do see that the relationship between CAM and pain varies depending on radiographic severity. So certainly it seems that disease severity needs to be accounted for when we're looking at the association between CAM and pain, but it's not the only one. Here, I've tried to explore factors associated with the participant, with the disease, and with biomechanics and measurement that may all have an influence on the relationship we're interested in. And the point I'm trying to make with this slide is there's an overwhelming number of factors that we need to consider. How should we approach this? Either we need really large samples to adjust for all of these factors, and if that's the approach, we probably need to work together in some multi-site work, or we need to consider some within-person designs where some of these factors will be controlled within the person. And that within-person design becomes pretty powerful. Here we see within person design that minimized confounding. And when we do that, we see a strong association between medial loading and pain. This work comes from Kendall Marriott and Trevor Birmingham, and it's data from 279 people with painful medial Neoa. Now, what's interesting about these folks is they had one knee that was more painful than the other. This group evaluated pain a little bit differently. They looked at pain change. They wanted to see if pain increased after walking for 6 minutes. And if pain increased after walking for 6 minutes, they were coded as someone who has an increase in pain compared to all others. What you see on this graph are quartiles, and I'll just focus on the quartiles, although there are more analyses in the paper. You'll see the reference group is the first quartile with the lowest CAMs. And we have our 4 quartiles, and if we take a look at that 4th quartile, the highest quartile, the people with the highest CAMs, the people with the highest CAMs had a 10 times greater odds of experiencing an increase in pain after walking. So within person design gave us a chance to see that association without all of the confounding. So it seems that loading is a key consideration in Neoa pain. Now I'd like to move on to our other reason. We've talked about nociception, we've talked about all these other variables that influence the relationship, but we haven't talked about the elephant in the room, which is that pain is a perception, and it's really complicated. So we know that there are other mechanisms underlying pain perception, and that pain as an experience is pretty complex. So let's take a peek at some pain mechanisms. So far, I've only talked about number 1, this nociceptive mechanism where we damage non-neural tissue inside the knee, and we activate the pain pathway. What we need to acknowledge is, at least in Ontario, about 28% of people who have knee osteoarthritis actually have elements of number 2 and number 3 as a part of their pain experience. Number 2 is peripheral neuropathic pain. This is pain that arises from a lesion or a disease of the peripheral somatosensory system. Now, the trigger can still be mechanical, but that trigger is a trigger to the nerve. And what we'll see is that pain is presented in dermatomal or cutaneous distributions. So we have some sort of compromise to the nerve pathway itself. In number 3, central sensitization, what we actually have is an increased responsiveness of the nociceptive neurons in the CNS. So what used to be or could be perceived as normal afferent input now gets perceived as pain. And here is where we can have non-mechanical pain provocation. Central sensitization is also tied with psychosocial factors influencing that pain experience. So in our nociceptive pathway, that first pathway we talked about, if we take a closer look, we'll see a nociceptive pathway separate from pathways that signal other forms of touch, and that these two don't really interact, that when we have a pain signal, it travels along the nociceptive pathway separate from other touch. In central sensitization, though, we see some changes in the pain pathway in at least 2 ways. In one way, we can see an increased efficiency inside that pain pathway. We could have enhanced synaptic communication, so we could have more neurotransmitter, we could have less inhibition to that pain pathway, and that will allow the pain pathway to signal pain with a lower threshold stimulus. And this situation is called hyperalgesia. Another situation that could emerge is allodynia. Here we see an interaction now between the normal touch pathway and the pain pathway. And the connection could actually facilitate the pain pathway. So we could actually have some normal touch stimulus that creates a facilitation of the pain pathway. And now we have what was an innocuous input being perceived as pain. Now, these sensory elements are only one small picture of a bigger puzzle around the pain experience. And the pain experience has multiple dimensions that could be split into inputs and outputs. Now, in terms of inputs, I was talking about the middle one there, the sensory, but we also know we have cognitive evaluative inputs. These can include attention to the pain experience, anxiety, depression, past experience. We also have motivational inputs, and these engage our endogenous opioids and limbic systems. So our emotions can get involved as part of those inputs. In terms of outputs, of course, we've been talking about pain perception, but there is also what actions we take, what coping strategies we have available to us, and voluntary and involuntary actions that are part of our pain experience. We also have stress regulation, cortisol, immune activity, endorphins. These all contribute. And while this is really overwhelming and complicated, it also gives us lots of opportunities to intervene in that pain experience. So now I'm going to move on to the key messages. And I hope that I've convinced you that, especially if we design the study right, we can see that strong relationship between knee loading and pain. But we must acknowledge that pain likely modulates knee loading, that there are many variables or factors that influence this relationship, and that pain is a perception that involves multiple mechanisms and is influenced by sensory, affective, and cognitive processes. So as biomechanists, what do we do now? Well, we need to acknowledge that the nociceptive model is not enough, and recognize that we're not just creating a loading exposure that creates pain, that clearly pain modulates knee loads. And I'm excited to learn more about that in the next talk. We also need to acknowledge that neuropathic and centralized pain exists in our samples. We need to detect it. We got to get to measuring it. We need to consider some designs, study designs that consider pain change, within person designs, and multi-site collaboration, not just in biomechanics, but with pain scientists. So that's all she wrote. I'd like to thank all of these wonderful people who have contributed to the research that we do. And I'd like to thank everybody for their time today.
That's great. Thanks, Monica, for a very thought-provoking talk. I think, again, this was really what we wanted to do today, which was kind of get the conversation started and really think about different ways of doing things. And just noting on one of the last comments that Dr. Maly made, I think there's two things that she said. One is we need to do more together. And again, that's part of the goal of the network, is to build out sample sizes and whatnot. But the other key point is to bring in other groups. And I know that as biomechanists, we started to do a pretty good job of integrating with imaging, and Dr. Maly's really led that. And I see Dr. Souza on the talk as well, on the call, as good examples for that. But I don't think we've done a very good job bringing in the pain scientists. So I think that would be a very good opportunity for us to move forward as a field. So that leads us into our next talk. And again, we'll hold questions until after both talks are done. So Dr. Katherine Boyer is an associate professor in the Department of Kinesiology at UMass Amherst. And she also has an adjunct appointment in the Department of Orthopedics and Physical Rehabilitation at the UMass Med School. Her research is predominantly focused on mechanisms underlying loss of normal joint and whole body function, associated with a number of different individuals, aging, muscle fatigue, joint pain pathology. She also focuses on development and evaluation of interventions to improve clinical outcomes based on musculoskeletal health. She's got a Bachelor of Science in Mechanical Engineering from Queens, a PhD from University of Calgary. She also did a postdoc at the Palo Alto Bone and Joint Center and Stanford University, and then again moved to UMass to start her faculty position. And just one last thing, she's recently been appointed as the new editor-in-chief of Journal of Applied Biomechanics. So really happy to have Dr. Boyer come and present and talk to us today.
Thanks, Michael. I'm going to hope I did that right. Okay, so thanks for inviting me. It's always exciting to get to actually talk about research these days. And I'm going to be here for the mechanics people in the crowd. So as Michael said, my background is from mechanics, and I'm here to convince you that considering pain, which I think scares a lot of us in the mechanics world, because it's a feeling, that why we should consider it in our mechanics-based research. So I'm going to thank Dr. Maly for setting me up nicely here to talk about this. So before we jump into a discussion on the interplay of pain and gait mechanics, let's take a moment to maybe review some of the common themes that we have seen in the OA literature to date. So gait mechanics right are of interest to us because they are the input signal for our joint tissues, right? So the kinematics, kinetics, muscle forces are going to dictate the joint mechanics, the tissue level strains, and therefore it's going to impact the morphology as well as our tissue and cell mechanobiology. So if we look and sort of summarize what we can see in the OA literature from a biomechanics perspective, I sort of think they fall into two categories, right? We have lots of studies that have quantified how gait is different in osteoarthritis compared to healthy controls and between different levels of severity. And we also have a large number of studies that are really focused on biomechanical markers that are going to lead to disease progression or initiation and progression, sorry. Right, so lots over here. And we've got some strong evidence to link biomechanics to disease initiation and progression. So if we look at the medial compartment NEOA exclusively, right, we have lots of now prospective studies that have supported a relationship between several surrogate markers for joint contact forces, including the knee adduction moment, magnitude, impulse, thrust, a few studies looking at the knee flexion moment, a few at coactivation, showing a link between the whole body biomechanics and disease progression. And these all have been nicely summarized in a recent meta-analysis. Now, if we look a little bit at some of the data that have come from these studies, we can see, right, so here we have on the y-axis, we've got the medial lateral thickness ratio change over a 5-year period of time, and we've got the peak knee adduction moment on the x-axis here. And we can see, right, we've got this relationship. It's not particularly strong, right? So, and this is pretty typical to see sort of a moderate relationship between these two. And if we look on the x-axis here, you can see a really large range. Right, so one of the questions we can ask is how much of this within participant variation is there, how much for an individual does this value vary, and on what time scale does it vary? Right, that would be important for us to understand. We've got a single snapshot here of an individual. We're trying to predict how much they will progress over the 5 years, but if this value changes from week to week or month to month, we may be limited in our ability to sort of understand this relationship here. So we want to sort of explore what are the factors that may sort of impact the individual gait variables, and on what time scale would they do this. So, right, we've got two primary factors that may impact the gait outcomes within an osteoarthritis population. The first, of course, is structure. Right, and this has been examined in a number of studies, cross-sectional studies. As the medial compartment cartilage thins, we see that there's a change, often a change in the joint alignment, moving us to a more adducted position, or varus for the clinical folk here. And as a result, we're going to get changes in the external force vector and in the moment arm, and we'll see increases in the knee adduction moment. And there are a few studies that have shown a correlation between the knee adduction moment and the limb alignment, or the structure of the joint there. So as the disease progresses, of course, we may see changes in the knee adduction moment simply because we've changed the alignment of the limb. And of course, the one we're going to talk about today is pain. And as Dr. Maly has nicely set up for me here, there are two sides to this story. right? So our interplay between pain and gait is complex, and it's not going to be a unidirectional relationship because mechanical loading can contribute to pain severity, but pain may also lead to our changes in the biomechanics. And we should expect this because pain has this important physiologic role in the body to warn us that something is going wrong. So if we think about the simple situation, right? So we've got our mechanical stimulus, we're going to activate some joint nociceptors, we're going to get a signal if it crosses some threshold of intensity, and we'll get this signal sent up through the dorsal horn to higher parts of the spinal cord. It'll go to your brain for processing, and you will have this sensation of pain. And of course, this is a very simplistic schematic here of how this all works. Now, what we're going to expect is that at both the level and of the spinal cord and the brain, we should expect some motor response to these noxious stimuli that will produce a motor adaptation, which has the goal of altering this initial mechanical stimulus. Now, in humans, we expect that we'll have a response both due to the activation of the nociceptors and a reflex response potentially, or a response directly from the spinal cord, but we'll also have a response due to the interpretation of those signals that's going to impact our complex behavior, right, that is walking. Now, it's been suggested that the goal of this adaptation is going to be to decrease the force, the motion, and or the variability of that movement at the site of pain. Now, it's of interest to us to understand if and how osteoarthritis pain leads to changes in the forces, motion, and variability of that motion, as it can impact progression, as we've seen this link between mechanics and progression. But it also may have significant implications for mobility and for falls risk, which are perhaps understudied areas in the OA biomechanics world. So if we have this goal of changing the mechanics, we would expect then that there would be some accompanying neuromuscular change that would produce these biomechanics, these alterations in biomechanics. Now, there's two longstanding theories for how this would happen. There's the vicious cycle theory, which suggests that we would see an increase in activation of all muscles surrounding a painful joint. There's a pain adaptation theory, which suggests that we would see inhibition of agonists and a facilitation of antagonist muscles surrounding that painful joint. And a third, more recent proposal that suggests the response is far more complex and that muscle activity will be redistributed within and between muscles in response to joint pain. Now, data to support these theories comes largely from animal and experimental pain studies where muscle pain has been induced, but there are a few that have looked at joint pain, and I'm going to talk about those in a minute. And I think if our ultimate goal is to understand the mechanisms for gait variation in NEOA due to pain, it would be helpful to see which of these models or how these models are relevant for the response to joint pain in a complex movement like walking, because that's where we're interested in the mechanics for progression. And the idea that it would be walking and not perhaps an open chain activity, like an activity on a dynamometer, might be important to consider. So to understand the impact of pain on biomechanics in the absence of structural changes, right, which can also play a role in the variance on our biomechanics, one of the ways that we can do this that I've been interested in exploring is using a within subjects design. So we have a couple of options in this way to do a within subjects design. The first is we can look at the response to pain treatment. And Dr. Maly covered that a little bit. And the second way is we can look at how the body responds to increases in pain. And we can do this looking at experimental pain models. We can look at how pain fluctuates with time in osteoarthritis and look at the change in biomechanics in the short term there. And we can also look at what happens when we induce pain or flare an individual's osteoarthritis pain. There we go. So most of the experimental pain models, as I suggest, have looked at muscle pain, and they found that there are changes in movement amplitude and velocity, electromyography amplitude, and motor unit firing rates in that painful muscle. However, there's also a few studies that have looked at inducing joint pain. And the joint pain model uses an injection of hypertonic saline into the infrapatellar fat pad, and then they compare this to a sham model where they also inject saline into the fat pad and then compared to a control condition. And there are now a few studies that have used this model, and the sort of largest number of studies have looked at what happens to knee extensor muscle function. And so if we look at the response here, we can find that knee extensor muscle function, we get decreases in isometric and concentric peak torque. There are decreases in the early rate of torque development and the rate of EMG rise in the knee extensors. And there's also changes in motor unit recruitment, both discharge and firing rate. So we see with joint pain, there is a direct impact on the knee extensor muscle function. And we know that knee extensor muscle function is important for gait. So we would expect there to be some gait response as well. Now, to my knowledge, there are only two major studies looking at experimental pain and gait mechanics. The first Monica touched on just a little bit, looked at overground walking, and they found that yes, there are decreases in the first and second peak knee adduction moments, but there's also changes in the knee flexion and extension moments. Given that the knee extensor function is impacted, that's perhaps not surprising. A follow-up study done by the group in Utah, Matt Seeley's group, looked not only at the knee mechanics, but also at the mechanics of the hip and the ankle. And what's interesting about their study is that they show that it is not an isolated response, right? That we have to have some coordinated response within our lower extremity in order to offload that knee joint. And they find changes in the peak support moment, hip adduction moment, knee flexion moment, and ankle external dorsiflexion moment, or that propulsion moment, as well as changes in the ankle plantar flexion angle. So this suggests that there's reduced ankle motion. We're changing the sort of the entire function of that limb in walking. So it can be a sort of a complex response. Now, experimental pain is very useful, right? It's a very controlled scenario. We can induce quite a bit of pain in there, but it may not tell us exactly what's going to happen in osteoarthritis. And part of the reason, I think, is there's a few factors that might impact our pain response. One is that we're going to have some age-related neuromuscular changes, right? We know that gait changes with age, and therefore our strategy to alter the mechanics of a painful joint may have to be different. We're going to have muscle weakness and disuse. There could be multiple sources of pain. We also have differences in our joint structure, again, all impacting the strategy that we might be able to use in order to offload that painful site. So we want to be able to look within an osteoarthritis population at how biomechanics and neuromuscular control may vary with different levels of pain severity. So one of the ways we can do this is looking at what happens over time. And by time, I mean a short time scale. So one of the sort of useful things about osteoarthritis pain is that it's a dynamic experience, right? And pain fluctuates on a weekly or monthly basis. And so within a person on a shorter time scale than where we would see changes in disease severity, we can see changes in pain. The other sort of unique thing about osteoarthritis pain is it's often exacerbated by weight-bearing exercise. And so we may also be able to harness this characteristic of pain in order to understand our biomechanical response. So the first study that I'm going to present is as a crossover design study where there were repeated washouts, and the goal was to test the impact of drug therapy on gait mechanics. But conveniently, there were multiple gait studies done over a 14-week period of time at the start and end of treatment and at the end of a washout. So we have a washout period and then a gait test, some sort of drug happened. We have another washout and another washout happened, and then we have a placebo treatment phase here. And when we look at the pain within a small group of individuals, we can see that at the end of each washout period, that the amount of pain that they had reported was slightly different. And so the question is, how consistent were the gait mechanics, or how repeatable were our gait mechanics over these 4 different gait tests? And if they aren't, can we attribute it to pain? So if we look at the intraday, so within a day, looking at the interclass correlation coefficients, or the repeatability of our gait mechanics, we can see that within a day, we're really good, right? And we all know this as biomechanists, that gait mechanics is typically very repeatable within a day. So we have really high values here. If we look between our days, so our inter-day ICCs, we can see that for the knee adduction moment, it's actually really high, right? And this is sometimes a bit surprising because we often think of the knee adduction moment as being what should respond to variations in pain, but it in fact is quite consistent day to day. Where we do see significant variation or lack of repeatability is in our knee flexion moment, in our walking speed, and in our cadence. So sagittal plane mechanics seems to be a little bit more sensitive to small variations in pain on the short time scale as compared to our knee adduction moment. So gait mechanics are not the same, but the knee adduction moment seems to be less sensitive to pain here. But what happens if we vary even on a shorter time scale, the pain within a joint? So this is something that we've tried to do to sort of allow us to more reliably or in a less challenging experimental design study the biomechanical and neuromuscular response to pain. And what we've done is we developed a treadmill walk protocol that we hoped would provoke pain in individuals with knee osteoarthritis so that we could capture the differences from start to end of their treadmill walk in their gait mechanics and in their electromyography. And the first time we did this, we took a group of knee osteoarthritis patients and then a group of healthy patients that were age matched and relatively sedentary to see what happened essentially. So the first thing that was pretty interesting, if we look at our individual responses, so I've got our individual participants here on the y-axis, and I've got the change in pain using the verbal numeric rating scale on the y-axis here, is that not everybody developed pain in response to our treadmill walk. So on average, we had about a 0.5 point increase in pain, but there's clearly two groups here, right? There's a group of individuals who do not experience pain with walking, and there's a group of individuals that do. Turns out for a biomechanics study, this is a great result to have. So what we wanted to do then was look at how gait changed in the individuals who didn't experience pain, the ones who did experience pain with a walk, and then compared to our healthy group who also did the same protocol. And we defined pain as a greater than 1 point change on our verbal numeric rating scale. So if we look at our response to our 20-minute treadmill walk for these three groups, we find some agreement to our pain theories and evidence of offloading of a joint when pain increases. So this tells us that one, gait is a pretty dynamic thing in an osteoarthritis population. It's not entirely a learned motion. It does change in response to different stimuli. So I've got our change in knee moment. And so a decrease means that we are offloading the joint essentially for our flare group, our no flare group, and our control group. And we find that there's significantly greater change in our knee flexion moment, our knee adduction moments, first and second peak, and our internal rotation moments in our no flare group compared to our no flare and control groups. And if we look at the magnitudes of these changes, they're quite large and much larger than we see in the experimental pain group. But we also see a lot of variance there. So the next question, of course, is the one I'm really excited to keep studying is how is this happening, right? So what are the neuromuscular response to this pain that may be leading to us offloading the joint? And here's where things get maybe less exciting. So to investigate our neuromuscular contributions to these gait changes, we quantified the EMG amplitude using a statistical parameter mapping. So looking at differences across the entire gait cycle, and wanted to see if there were differences in the change between our group who did not experience pain and the group who did experience pain. And we find that there are no differences at baseline or in response to the 20-minute treadmill walk in the EMG amplitude of our knee extensor or flexor muscles across the gait cycle. It's a bit disappointing. I expected, because we had changes in the knee flexion moment, that we would see differences here in the amplitude or in a co-activation index, and neither happened. So this led us to sort of take a step back and repeat the study, and this time include some dynamometry, right? Some simpler measures of knee extensor function to see if there in fact is any change in the knee extensor function or not. So this also allowed us to replicate our study and to see whether we were getting similar proportions of patients who responded to our treadmill walk protocol. And indeed there was. So we found similar, about half of our patients experienced an increase in pain with the treadmill walk and the other half did not. And then we have two primary outcomes. One is our isometric peak torque, and the other is the rate of torque development. And if you remember from the experimental pain studies, both of these metrics decreased in response to experimental pain. So to sort of maybe disappoint some in the crowd, we did not find any changes in the peak torque with the treadmill walk, nor did we find any differences between the pain and the no pain groups. So in our rate of torque development, we looked at two intervals. We looked at the first 0 to 100 milliseconds and then the second 100 to 200 millisecond period of time. And it's this early one that previous studies had found differences with pain. And what we find is that, yes, with our 20-minute treadmill walk, we do see decreases in the rate of torque development, both early and in the later interval. But there are no differences in the recruitment pattern or in our torque development between the individuals who did and did not experience pain. Now, there is a lot of variation here. And so this is a small study, so maybe we're missing something there, but it doesn't seem that this model here is helping us understand the neuromuscular response to variations in pain and osteoarthritis, which is a bit disappointing, but leaves us much more to do. So just to wrap up, right, one of the questions I wanted us to think about today was how much of our variation in gait mechanics between and within participants is related to symptoms. And so what we find is that with pain, gait mechanics do change on both an acute and short time scales. This seems to be primarily our sagittal plane and spatial temporal measures, which is are more directly linked to our knee extensor function. So perhaps not surprising, given that that is where, that is the experimental pain studies show us that that is a key site of response to pain. And we find that the knee adduction moment variation is less related to pain on these short time scales. What remains an exciting area for future study is to understand the neuromuscular response to osteoarthritis pain. We find no differences in our change in EMG amplitude, the peak torque, or rate of torque development between individuals who do and do not develop pain while walking. But I think there's much more to investigate there to be able to understand the mechanisms for altered biomechanics in an osteoarthritis population. So I'm going to leave it there, and I just want to thank my students and collaborators and our core facilities where we did most of this work. And I look forward to a discussion on how we can explore these topics more.
Great. Thanks again, Catherine. That's another fantastic talk, trying to delve a little bit deeper into what we're trying to see and trying to measure with respect to pain as it pertains to biomechanics, and then, of course, ultimately with an intervention. So I'm going to open it up for questions. Feel free to use the hand function and unmute yourself and turn the video, or I'm happy to check out the chat box as well and moderate any questions from that perspective. So any questions that you've got for Dr. Maly or Dr. Boyer based on their talks, again, recognizing that we will have a panel discussion probably in about 5 or 10 minutes. Dr. Souza, we'll start with you.
Dr. Maly, Dr. Boyer, fantastic talks. Thank you. That was really great. My question is about the ability of individual participants to change their gait mechanics. For anybody who's tried gait retraining studies, we see that some people are really good at it and others are not. I wonder if you can just speak to your experiences with individuals' ability to change gait mechanics. Is it something that pain is a motivating enough stimulus that this will just kind of come about? Or is it something that we need to work better at kind of understanding how people change their gait mechanics and develop better gait retraining models?
Maybe I'll start. So that was one of our questions when we developed our treadmill walk was, is there even a potential to alter your gait when your pain varies, especially on a short time scale? And I think some of our initial grant reviewers told us that it was all learned and we were going to find nothing. So we do find that pretty consistently when either from week to week, if a person experiences a change in pain, or within a session, if they experience an increase in pain, that there is a response. The magnitude of that response seems to vary from person to person, but everybody who experiences pain seems to have some sort of response. So it does seem to be a strong enough stimulus that it overcomes whatever pattern of motion you have learned prior. How it happens, I have no idea.
I'll just say I haven't done any studies involving gait adaptation, so I really have nothing to add to what Dr. Boyer has described, but I do wonder if Dr. Hunt might have a couple of comments.
Yeah, I would echo what Katherine says. I think, you know, at the end of the day, we can do a relatively good job of teaching people to evoke some sort of change in their kinematics. Whether that has a direct impact or direct effect on the kinetics is a bit of a different question. And then, of course, from the long-term perspective, that's really the key question. You know, we've done a number of studies even out to 4 months, and people do well in terms of changing their kinematics and kinetics. But after a month without sort of supervised contact and whatnot, they do start to regress back to their baseline. So I think one of the things that we're trying to do now is see what's going on in the real world using wearable sensors. And I think that's going to be a real game changer in terms of what actually happens when someone walks outside the lab and we don't see them for a week. Are they actually doing it? And if not, what's going on? And then, of course, the last comment would be exactly what happens throughout the week as there are fluctuations in pain. Do they change or do they use that as a positive reinforcement?
Thank you. That's exactly what I was looking for. I think the real world monitoring of that is really what's critical. We did a gait retraining study, and once the context of the walking environment changed, we struggled with getting them to maintain the learned pattern. Thank you, guys. Thank you both.
Yeah. CLK, I think that's you, Cheryl.
Yeah, yes, it is. Thank you. Okay, great talks, both of you. A lot of ground covered and lots of really valuable and interesting information. And I guess my question sort of related to your sort of comment on the diversity of pain measures that are being used in these studies. Given the complexity, like we have different neurophysiological pathways, as you nicely pointed out, Monica, in your paper. So there's physiological ones, but then you have your psychological ones, including cognition. And if the complexity of pain and the simplicity of some of those measures versus as well, we have a diversity of gait metrics that we're using. And I think there's kind of a clear differential coming out between using a peak value, for example, with the knee adduction moment versus what information is coming from the measures that are looking at overall magnitudes, like your impulse or your PC overall magnitude. And I just want to know if you could comment on how that might impact some of the results. And I think it's sort of, you know, one of the things, Katherine, in your study, like you were using WALMAC on the crossover study, I believe, and whether you did do any measurements during the gait assessment. Long question, but if you can just make some comments on that.
Maybe I'll get started on this one. I think the diversity in measurements is an issue that we need to contend with. In terms of pain measurement, I really hope the pain scientists that have joined us will give us some direction on improving our measurement of pain. But I'm aware of Pain Detect amongst other measures that could be more sensitive to other types of pain other than the nociceptive And so I'm hoping to learn that, and I can see lots of place for collaboration there. In terms of the different measurements from the CAM and then the different biomechanical measurements, I do agree with that comment that the measures reflecting overall loading seem to do a better job with relating with pain. And I'll just echo Dr. Boyer's comment about the sagittal plane. And of course, it makes sense that where we have more neuromuscular control in the sagittal plane, we're going to have more sensitivity to changes there.
I don't think I have much to add. We have used WOMAC and the KOOS as sort of measures on a data week-to-week basis. And then within our treadmill walks, we use a visual analog scale or the verbal numeric rating scale as a more momentary assessment. And I think I don't have good reason behind using one versus the other in different scenarios. I know in our crossover design study, we also had visual analog scale measures at the start of each gait test. And it's been a long time since I looked at that data, but I do believe we had sort of the same conclusions independent of which pain measure we used for that. But yeah, I think we could benefit from some knowledge in this area to help design our studies.
Great. Thank you very much. That was great. And I think one of the things is with some of the pain researchers that I've been working with is like they are really keen, and this might come up later as well, but on looking at pain behaviors. And maybe gait is one way that we can get at understanding some things around pain behaviors, like we do with rats and, in animal models and those types of things. They really rely on that because they can't ask a question. So great. Thank you very much.
And I think that's a great question, Cheryl. Hopefully that will be discussed a little bit in the panel discussion, because, I think if as researchers, we don't want to put a lot of time and effort and resources into something if we're asking the wrong questions or collecting the wrong data. We want input from multiple different people in multiple disciplines to ensure that we're getting the right information. I see a couple of questions in the chat box. I guess I'll start from top to bottom, from starting with Dr. Jim Gregorio. Some of the rationale for strength training in Neo-OA is to build muscle size and strength, since soft tissues can then take up the load energy. How important do you think muscle size and or strength is to the pain experience or to disease progression?
I think that's a great question. And I think it's something that we haven't explored as a field enough. And I think where this could be important is understanding our ability to respond to a perturbation, right? We often think about responding to a perturbation in terms of recovering from a fall, but I think a perturbation can also be joint symptoms. And so the potential to adapt your gait to respond to a stimulus from your joint may actually be higher if you have a better functioning muscle. And so that could be size or strength or power. And so exploring that relationship, I think, is potentially fruitful.
And if I may add a couple of points, I would suggest that there's probably a role for muscle to redistribute loading across the articular surfaces. And if we strengthen, we may have the opportunity to reduce the relative demand for that individual. So it just costs them less to get through their activities of daily living because we've increased their capacity. Just a couple other ideas.
And just to throw a wrench in it as well, and going back to what Dr. Maly said earlier, the literature is pretty clear that, if you put someone on a strengthening exercise program, they will improve pain. And, that's one of the reasons why exercise and physical activity is a core treatment approach for OA. I'm not familiar with many, if any, studies that have shown a similar change in knee biomechanics from a gait perspective after an exercise intervention. I think that just speaks to what Monica was saying earlier, but is that the relationship isn't as clear as people might think, and that there's a lot of things to consider.
And I'll just add on to that, because I think we can learn a lot from these strengthening interventions in older adults, in asymptomatic older adults, where similar findings, right? So it's not restricted to an osteoarthritis population. When you strengthen an older adult with the goal of restoring their young gait mechanics, we find improvements in things like walking speed sometimes, but not the changes to restore a young biomechanics that they would have. So it seems to be sort of more of a universal finding than we would only find in osteoarthritis, where strength training is not altering the mechanics in the way that we thought it might.
Yeah, great point. I see 2 more questions in the chat box. I think maybe now is a good time to transition to the panel discussion, because I'd love to get, I'm looking at the 2 questions from Dr. Costello and Dr. Atkinson that are very, I think, very relevant to the larger group. And so, again, if anyone has any questions, feel free during the panel discussion, specifically based on the talks, feel free to bring that up. But I think we'll now transition into the second part of today's event, which is the panel discussion. So we're really fortunate to have 3 great clinicians, 3 great clinician scientists, 3 great researchers. Might not be as familiar to some of you in the gait biomechanics world, and I think again that was one of the reasons why we wanted to bring this event together to bring that extra perspective. So our first panelist is Dr. Tuhina Neogi. She's Chief of Rheumatology and a Professor of Medicine and Epidemiology in Boston University Medicine and Public Health. She's a rheumatologist and also a PhD trained epidemiologist. Her research predominantly focuses on osteoarthritis and gout, mainly pain mechanisms and methodologic issues for relevance, which I think again is going to be important for us today. She's received a number of awards. She got the 2014 American College of Rheumatology Henry Kunkel Young Investigator Award. She won the 2016 Robert Dawson Evans Research Mentoring Award. Again, it speaks to her clinical prowess, her research prowess, and her mentoring excellence. She's also been involved in development of classification criteria for rheumatic diseases. So I think, again, she'll bring a very important perspective. We also have Dr. Lisa Carlesso, who's an assistant professor in rehabilitation science at McMaster University. She has training as both a clinical epidemiologist and a physical therapist. Her research program is focused broadly on mechanisms and consequences of musculoskeletal pain, with a particular focus on OA joint pain. She looks at complex mechanisms of acute and persistent pain. So that's one of the reasons why I parked one of those questions. Through pain phenotyping to improve both prognosis and treatment, which I think is important. And using the understanding of endogenous modulation of pain to enhance conservative treatment approaches. And then finally, improving clinical measurement of pain. So again, a very broad pain-focused discipline and research that will be important for us to talk about today. And then finally, we've got Dr. Timothy Wideman, who is a licensed physiotherapist and associate professor at McGill University, Montreal. He uses biopsychosocial risk factors and how they're related to pain influence, activity and engagement with rehabilitation outcomes. He's received several national awards, including a new investigator award from the Canadian Institutes of Health Research and a mentorship award from the Canadian Physiotherapy Association, and really interested in kind of tying together pain, physical activity, and rehabilitation. So welcome to the 3 of you. And maybe to get things started out and get you, for the group to kind of know who you are. Maybe if there's one thing you just want to say based on what's already been discussed this morning, or something that you want to kind of start the conversation, either a well-known thing or maybe a controversial statement, I'll leave it up to you. So Dr. Neogi, maybe we'll start with you. One thing to get the ball rolling.
It's hard to choose. I've been having to sit here on my hands, not jumping in to contribute to the conversation so far. So first of all, Monica and Katherine, great talks. That they were really wonderful overviews, and I think that interrelationship of sensory input affecting motor output is something that there hasn't been enough work done in that area. And so I will say, I think that moving beyond pure nociception, and Monica, what you were raising about how facilitated ascending pathways might be impacting motor output, I think is an understudied area. And I'll just throw this out there. One of the studies that we did in the multi-center osteoarthritis study, where basically all of our pain mechanism studies have emanated from, we found that evidence of pain sensitization was associated with more coactivation. And so, I think there is a story there that needs further sussing out about how alterations in pain mechanisms, ascending pain signaling, affects that motor output.
Great. And Dr. Carlesso.
Great, thank you. Thank you for the invitation and great talks, Monica and Catherine. I will, based on the question about strength and what Tuhina just said, I'll bring back to people's minds a study that came out earlier this year by Steve Messier that showed that, many months of high intensity training versus low intensity training versus an attention control group, which I believe they just received general education. I don't even think it was specific to OA. There was no difference between those three groups in terms of pain relief. And so while we have, many studies showing the benefits of strength training on pain in NEOA, then we get something like this, which really points to, I think, the importance of that psychosocial aspect, self-efficacy, the impact of education. And so it just speaks to all these confounding variables that have been well highlighted, and how do we go about sussing those things out?
Great, thanks. And Dr. Wideman, last comment to you, just get the ball rolling.
Great. Thanks so much for having me. It's a pleasure to be here. Yeah, I love the presentations. I think they were really great. I think one of the core messages that I received is that pain is this kind of big, messy, complex phenomenon. And I think because of that, there's this reticence to kind of get into it and kind of engage with that complexity. And I understand that inclination. But I would encourage you folks who have more of a background in biomechanics to try to find avenues to engage with that. And would love to chat about strategies. And I think, that those different strategies that were highlighted in the talks are really encouraging in terms of, trying to get more nuance, trying to get more depth in terms of bringing some of that complexity into these research models. So I think it's really exciting.
Great. So we don't really have a formal agenda this morning. I wanted to keep this kind of relatively open and relatively free flowing. I'm looking at the clock, and we do have about 45 minutes. I don't want to speak for others, but maybe we'll go over. Maybe we'll start. Maybe we'll finish early. I don't know. We'll see how things go based on the discussion, and maybe how controversial and how beneficial the talks are. So I'm going to start. I'm going to call on someone who put in a question at the registration phase, and that's Jacqueline from University of Waterloo, who had a question. If you wanted to unmute, Jacqueline, I think you're there. You are. Yep. Who's a postdoc at University of Waterloo.
Yeah, thank you for the wonderful talks and for everybody being here. So my question was about collecting pain measures during experimental trials, be it an exercise intervention or otherwise. And I was wondering if anybody could speak on what the best practices for collecting this information might be, how frequently they should be asked, should we normalize it to a daily baseline or just use individual ratings, anything along those lines.
So did you
go at it?
I mean, some others might know. As far as I know, I don't think there are kind of core guidelines or best practices, and I think this is part of the issue, is that it's still a little bit of the Wild West in terms of how to approach these types of measurements. But I think that we can talk about specific strategies, and maybe that would be helpful. But I think an overarching idea is just to think about like why you want to measure pain and what you're trying to get at. And I think that Dr. Boyer's example of looking at physical activity, looking at pain responses in relation to that, and then using that as a subgrouping to look further into the biomechanics, I think that's a really interesting model that in my mind has a lot of relevance to clinical populations, because what part of what we're interested in is why are certain individuals, why is physical activity or certain types of movements provocative of pain, and for other individuals it's not, or can we look into nuances amongst individuals that do have this link between movement and pain. And so using your assessment strategies to get at those relationships that are important for your research questions would probably be the core overarching guideline before we kind of get into the weeds of it.
Yeah, I was going to sort of say the same thing. I think whenever embarking upon a research study, take a step back and first establish what's the research question, because that's going to inform how you're going to set up your study. So for some of our studies, we assess pain before we do any functional testing, and then we assess pain immediately after completing a specific functional test before moving on to the next one, et cetera. So we have the data collected, but then when it comes to analysis, we sort of think about what's the question we're trying to ask. And I think the other thing, I just wanted to go back to what Lisa was pointing out with the Steve Messier trial. I think in OA studies and OA management, we still have this idea of a one size fits all. And this is first line for everybody. And we've been doing much more of this thinking in structural targets for OA and OA trials for D modes, but we've not really talked about this for pain trials. Everyone comes into an OA trial with KL 2 or 3 with a pain level of at least 4 out of 10 or whatever the standard's going to be. And we don't actually think about pain phenotyping. And with the Messier trial, there's also, some people don't get exercise-induced hypoalgesia. Some people have a paradoxical response. So we might be setting up some of our patients for failure because we have not phenotyped what the appropriate therapy is. And so I think a lot of those nuances also need to go into these biomechanics studies. There was a really nice study by Kim Bennell, and I don't remember which year it was, but I can't even remember if it was a shoe insert or a knee brace, but there's a lot of controversy about whether shoe inserts or knee bracing works. And in that trial, what she did was she first ran participants through and saw if they had the expected reduction in knee adduction moment. And for those that didn't, they were not in the trial. And so she screened ahead of time for, is this intervention expected to work for these individuals? And so I think much more nuance needs to go into thinking about OA rather than just this conglomeration of KL2-3 with a certain amount of pain.
And if I can just build on that a little bit with your comment about phenotyping, Tuhina, just to encourage you also to think broader than pain simply in terms of intensity or severity, right? We have different measures now. We've got the ICOPE, which we know has been validated against disease progression. So we can look at qualities of, is that pain intermittent? Is it constant? We can look at the qualities of the pain themselves using different scales. Is there burning? Is there pins and needles, et cetera? You can look at the temporality of the pain. So there's lots of different aspects of pain that are very interesting to study and to bring out those nuances that are just beyond that 0 to 10 intensity scale.
So one thing that Monica raised near the end in response to a question was pain detect. And I'll just get on my little soapbox for a moment because I think it's very controversial in OA. So a certain threshold. So first of all, just back to first principles of it was developed to distinguish radiculopathy from mechanical low back pain. And OA was part of the control group. And then Jackie Hockman and Jillian Hawker, they adapted it for use in OA. And the threshold for neuropathic pain is lower than on the traditional pain detect scale instrument. However, in OA, we have not actually demonstrated that there is a neuropathic lesion. And so as Monica nicely outlined in sort of the definitions of what's neuropathic pain, there needs to be a lesion or a disease of the somatosensory nervous system. And so you'll see in the literature nowadays much more use of the term neuropathic-like pain when describing the pain detect findings in OA. And not enough studies have been done to really understand what is pain detect telling us. It's telling us something similar to pain severity. It correlates very nicely with WOMAC pain, but it's beyond just severity. There's something about the quality of pain that people are experiencing that has distinct pattern of associations than WOMAC. So is it nociplastic pain, peripheral or central sensitization? There are, Jackie Hockman did a study with evaluation against QST, and there's some associations there. So I just want, I think for one of the problems for us, and maybe Tim, you'd like to weigh in on this, but when people are not specific with their language, and the words matter. And so I think when we're trying to invoke mechanism, we should need to be a bit careful about what we're interpreting. Just like in OA, we understand there's a structure symptom discordance. Just because someone scores something on pain detect doesn't mean they have neuropathy.
I don't have too much to add to that. I think other constructs or questionnaires that come to mind is looking at something like a central sensitization inventory. So looking at like a broad sensitization process and bringing in heightened sensitivity to other aspects of perception, like bright lights or sensory factors, and also just kind of pointing towards this broader kind of pattern around how the nervous system is working, so that there are other tools out there as well.
I'll just jump in on what you said there, Tim. So we've done some work looking at the central sensitization inventory and QST, and I think it's just important for people to realize that the constructs that are likely being measured by that self-report measure versus the physiological changes that we register with QST are not necessarily the same thing, and they seem to be poorly correlated. We've just done a rash analysis of the central sensitization inventory, and now we're reevaluating it with the QST to see if it has made any difference or not. But it seems to be kind of more related to kind of psychosocial constructs. And probably I think that has a lot to do with the fact that it was developed on people with central sensitivity syndrome. Neo-OA, people with Neo-OA were not part of that group. It was people with irritable bowel, fibromyalgia, etc. So I think that's something just to be aware of if you're using that tool.
Okay, I think we'll switch gears. And I know that looking in the chat box, Dr. Costello, you had a question.
Yeah, thanks. So thanks, Katherine and Monica, for the great talks. I was thinking about the fact that a lot of these really cool results that you presented came from studies of acute pain changes. So whether that was induced pain or pain treatment or pain change after physical activity bout. So I was wondering if the two of you or the panel could comment on how that relationship between pain and biomechanics might differ when we talk about chronic OA pain versus these acute changes in pain.
Yeah, I can jump in that, at least to start the conversation. I think, mentioning earlier that pain is this big kind of messy, complex phenomenon. And there's just a ton of stuff that we don't know about pain and how it works. But one thing that we're fairly confident about is that acute pain and experimentally induced pain is not chronic pain. And there are important differences that are happening really kind of all across the body, and in particular related to the nervous system, that are happening when pain sticks around for a long period of time. And those are related in part to some of that sensitization processes that we talked about, but also really kind of, you need to think about those in terms of just the person who's living with this experience. If it's been in their life for a long period of time, there's a really good chance that's been majorly disrupted for them. It's influenced how they think, how they feel, and their relationships with other people, and often kind of important life roles. So that all of that aspect, that those changes to the body, changes to how they think about themselves, changes to their life, you don't really get that with an acute or experimentally induced pain. That's not to say it's not valuable, but it's different.
So Carrie, I'm going to call on you to share some insights that you've found with, obviously in the MOST study, it's 3,000 individuals. We can't do the fancy gait lab, gait biomechanics, but we have our poor man's version where we can put 3,000 people through. And I think some of the work that you've been doing highlights some of this pain biomechanics stuff, which you can, just help share with us. But I also wanted to also have you comment on Carol Lewis's insights from the MOST data that in these smaller samples where things look like the curves don't look like they are within the realm of what one might expect, some of those trials are thrown out. And what Kara was commenting on this large group of data is that the patterns that we see that often in smaller samples might be considered outliers, but there's a lot more of that going on in these curves. And so Carrie, maybe you could comment on both aspects. One is your approach to taking this very complex data to look at pain with biomechanics. And then secondly, the variability and range of those patterns.
Sure. So I think we covered this a little bit in the last OA session of the of using the large data set from the MOST study is that we can start to account for a number of the factors that were mentioned in a few of the talks that might be confounders. And we also can see that, as Tuhina was saying, there is quite a range in terms of the gait patterns, and some of these are not necessarily, they might get thrown out from a smaller study because they look different than the other ones, but there's actually a bunch of them if we look at them in a larger sample. So again, like some of the, as Cheryl commented, some of these methods that are using principal component analysis or looking at impulse or other ways of looking at these waveforms to capture more of that signal might be helpful in teasing some of that out as well. I'm not sure if that fully answers your question, Tuhina, but there's a few thoughts there.
Yeah, I'll just add to kind of just going back to what Tim was saying, the acute versus chronic pain. In our phenotyping study that we did on pain susceptibility phenotypes, we had the presence of pain catastrophizing, sleep quality, depressive symptoms in there. And we looked along with a host of QST measures, and then we looked at in these people that were relatively pain-free who went on to develop pain 2 years later. And the defining factor of these phenotypes was pressure pain threshold sensitivity. But what was really interesting was that none of these, the cognitive emotional factors, had any relevance in the phenotypes. They were pretty much identical across the 4 groups that we found. And I would agree with Tim, this is because these people are not in any particular pain at that point in time, and so they don't have all these other factors that are influencing their pain experience. When you look at people with chronic pain, I would assume these things in most cases would be much more prominent. And so I think in terms of looking at pain and biomechanics and acute versus chronic, I think the within person design would be particularly beneficial when studying the chronic population, because you can control for a lot of those confounding factors. And thanks to Tuhina for your that great design that you did so many years ago that people are replicating now. So
yeah, you see me smiling because
yeah,
I had no idea that the biomechanics world was has taken up my study design.
Monica or Catherine, anything to add to this?
We'll add, but I'll add from a biomechanics point of view. And I think the idea of large studies is always quite overwhelming for us because stuff in the gait lab takes forever and it's high manpower. But we do now have options, and The rigor and reproducibility of using wearable sensors still needs to be addressed before I think we can start to answer these questions about the interplay of pain and biomechanics. But I think the biomechanics in the real world, once we have that part of the study design done with knowing what we're measuring it and how reliable we are with wearable sensors, can be a way that we could maybe start to tackle some of these questions in larger populations and on more than a snapshot type measurement that we get in the lab. But I'm pushing for the rigor and reproducibility of those wearable sensors first.
And plus or minus a multi-centered network collaborative design.
Network across Canada, yes.
Or
yeah.
internationally.
Sure.
Tim, you get your hand up?
Yeah.
Yeah, well, I think that raises the potential or advantage of collaborations. So you have folks that are looking at like daily patterns in pain, using prompts on their iPhone to look at momentary fluctuations in pain over a period of time, looking at how that influences daily life. And so those would be large databases that are being collected. It'd be an interesting thing to use that data to zoom in on parts of that population to look at certain patterns of pain that have some potential relevance to biomechanics, and then do focused analyses using that data, so that you're taking advantage of the broad high number work, the high end work that people are doing, and trying to zoom in and focus on the laboratory work that can kind of complement that, and maybe by doing so kind of zoom in on the clinical problems that either might most likely be addressed with biomechanics or might not. Just some ideas.
Monica, go ahead.
Thanks. Just to add to these great comments, one little tangent, I think markerless motion capture is going to be in the picture in terms of trying to help us move forward with following trajectories and following large samples, particularly if we're collecting in different places. And then the other thing that didn't fit into the talk, there were lots of things that didn't fit into the talk, is the trajectories for people with knee osteoarthritis vary. But we have to recognize that about 50% of these folks don't change much in pain over time. And I think, the pain phenotyping Dr. Carlesso mentioned, like we need to be aware of who it is that we're studying in terms of their pain type and their likely pain trajectory, if we really want to get dig our heels into this complexity. Thanks.
So I'd like to just jump in on that point about the trajectories. I'm now going to geek out on methods here on how we assess pain. And this is controversial, but I think we really have to ask ourselves if our pain instruments that we use in OA, like WOMAC, are really fit for purpose for assessing pain annually over 5 years. So you'll see no matter what cohort pain trajectories or even function trajectories are assessed in, at baseline, everyone starts at a certain level. By year 1, everyone goes down and then everyone stays flat. And we know clinically that is not what's happening to our patients. So is it our instruments that are they fit for purpose? There's regression to the mean. People come into even cohort studies, non-intervention studies. They have an interest in the study when they're having symptoms and et cetera. And then people accommodate over time. So what someone says is, 6 out of 10 pain today, a year or two later, when in an observational study or even in a trial, they might still say 6 out of 10 pain, but things have improved. So either their pain improved and now they've increased their physical activity up to that level of pain that they were able to tolerate before, or they've frame shifted and said, well, back then what that was really like a 2 out of 10, and like right now 6 out of 10. So it's a whole mess in assessing pain longitudinally. And I'm really concerned that we're missing some signals because of these instruments and not really accounting for these types of things. And then the other is, physical activity is really important, but it's really behaviorally motivated and behaviorally mediated. And again, in the MOST study, when we did when we first started with our accelerometry evaluations, we found no difference in physical activity between people with knee pain, without knee pain. And we know from Lynn Snyder-Mackler, after knee replacement, people don't increase their physical activity. Our most effective pain intervention, and they don't increase physical activity. So that's not going to be the answer either. Then Grace Lowe has published on a pain per unit of physical activity that seems to have a little more sensitivity. So that might be an approach. Also a very anecdotal observation, even gait speed. So the most studies in Iowa and Alabama. In Alabama, they just walk slower. It does not matter if they have pain or not. It's just a cultural thing. That's just the way they walk. Everything's slow. So I think there's a whole host of contextual things that we have not yet tackled in OA.
So Cheryl, I see that your hand's raised, but I think this is a good opportunity. There was a question from Jesse Charlton, who's a PhD candidate here at UBC, from the registration side. I think that it's a nice follow-on from what Dr. Neogi just said. So Jesse, I'll let you ask it now.
Awesome. Thanks, Michael. And thank you to everyone, all the speakers. It was really, really informative this morning. Building off of that, Dr. Neogi, I'm wondering, when we are screening people for clinical trials and we want to bring them in eventually for their baseline, obviously we need to figure out if they're eligible up front, and we usually use some type of cutoff. Maybe it's, a 3 out of 10 on an NRS or something. But as you say, pain fluctuates, it changes. And sometimes we get people who come into baseline and they baseline with 0 out of 10 pain or 1 out of 10 pain, and now they are quote unquote ineligible. So I wanted to get your thoughts and everyone else's thoughts on, are there better tools we can maybe use, better methods in our way of screening people into these studies, so we're actually getting people into the intervention portion with pain that we can intervene on. Hopefully that makes sense.
Yeah, no, it does. That's a really, really tough question. And I will defer to others who are more involved with clinical trials if they have an approach or an answer. But I think this, like every OA trial sponsor has this question of how do we deal with this? So you want to have people with a certain level of pain so that you can see if your symptom modifying agent actually reduces pain. And so if their pain is fluctuating and there's a regression to the mean such that everyone goes down to 1 or 0 by the time you're starting the trial, you're not going to be able to see a signal. I don't have a specific answer. The types of discussions are around repeated assessments in a run-in period, things, but I don't know of any specific methodologic study that has compared one strategy versus another. And I will defer to others because I don't really do a lot of clinical trials.
Tim or Monica or Lisa, go ahead.
Yeah, I was just say that I know that studies that have used the EMA approach, looking at multiple ratings and averaging them across the days, that I'm pretty sure the 1 week period of EMA data collection has been validated to a single NRS question of what's your average pain been for the last week. I'm not sure of periods longer than that. I don't know if others might know of that, but I guess that could give you some confidence in a week period at least. But again, when you look at the variability of pain, as I think, yeah, I agree. We need to come up with different ways and a better metric. And maybe we could look at extending that 7-day period out a bit longer, but then, what's kind of the representative time frame that's adequate as well. So.
Yeah, no, I would think, I don't know if there's exact consensus, and I don't know if you really expect to find that in the field, the pain research field, but I would point to ecological momentary assessment as like an emerging gold standard in terms of just trying to capture what's going on in the daily life of people with pain. And I think that it's fair to expect variability, and it might be variability down to 0 at times. It all depends on what you're trying to study, but it's just trying to, that would probably give you the most comprehensive picture how pain is fluctuating throughout a period of time that could be used for intake for a treatment potentially.
So Carrie just pointed out, oh, sorry, go ahead.
No, I was just going to contrast that with, I think like a older version of how we kind of looked at pain would just be like, fill out a questionnaire that looks at your present pain intensity 0 to 10. And it's just seems like such a crapshoot in terms of like what you're going to get. And you don't know what they just did before that. You don't know what's going on in their life or how representative that number is going to be. And so you wouldn't really expect to have a meaningful sample of a representative population, or a sample that's representative of a certain population that's in any way kind of specific with that kind of measurement strategies is my comment.
I was just going to point out that Carrie shared in the chat a nice example of regression to the mean for when people are entering OA trials. And I think, Tim, your point of what did they just do when they're answering the pain questionnaire, the other thing that pharma sponsors often grapple with is what to do with people's background pain meds. Should they be off their pain meds when you're assessing their pain, et cetera? And, is a 4-week assessment, like weekly or daily for 4 weeks, is that enough time to understand what their typical pain pattern is like? Or are you still going to get regression to the mean after that 4-week period of time? So it's really, I think, challenging to, I don't think anyone's really figured it out yet. And I think for OA, the therapy, if it's going to be really, really effective and really able to separate from the comparator arm, these things probably don't matter so much. The problem for us is our interventions so far have very small effects. And so these things on the edges really do matter.
Monica, comments on that? My only comment would be is, again, thinking about getting the right data, but also recognizing the participant burden. And, my experience has been, at least the more you ask of people, the more likely they are either to drop out or have a negative result, which may or may not be related to the actual intervention. So I think that's something to keep in mind as well.
And one more thought, sorry, I'll jump in, is that if we sample them too frequently, they'll just refer to the last number that they gave us, right? Like they're just giving you kind of what they think you want them or want to hear. So that sampling frequency piece is a little bit tricky. Not enough data to see the signal change, but too frequently, and that burden actually will contaminate the data that you collect.
I know probably many here may not have attended the American College of Rheumatology conference, but there was a really interesting abstract from the Manchester group, from Will Dixon's group, presented by Arani Vivekanantham, where they used either like a watch or an app. I can't remember what the device was, but Will Dixon, he's known for that big study, Cloudy with a Chance of Pain. And so in this particular sub-study, it was just 25 or 26 people, but they had daily pain assessments and monthly KOOS. And you could see the daily pain fluctuation was all over the place, and KOOS was not necessarily anywhere near what the daily pain ratings around the time that the KOOS was taken. Now, they haven't done any sort of time lag analyses or anything. It's only 25 people, but I think it was just such a nice visual illustration of what daily pain ratings are and how they have nothing to do with the KOOS monthly ratings. And then the other interesting thing that she presented was that people who had sort of consistently low levels of pain or consistently high levels of pain had, on average, higher levels of physical activity than people who had lots of pain fluctuation. People who had lots of pain fluctuation had lower physical activity. And so we don't understand what that means. It's only 25 people, but interesting food for thought. And Carrie is on top of things today. She just put it into the chat what that abstract was.
Mm-hmm. Yeah, and pain fluctuation, there's some literature as well in the pain world that links pain variability or fluctuation with disability as well. And that kind of makes sense from a clinical standpoint. Like if you think about having these kind of periods of boom bust, so there's a lot of, you might do activity, flare yourself up, and then have a period of time when you're really not doing much kind of thing. And so, part of the educational approaches and interventional approaches that you might use in like a rehab context would be try to smooth those out from a variability standpoint.
Yeah, it was an interesting discussion because some of the things that we've thought about with the ICOPE, the intermittent constant and OA pain, is the unpredictability of pain has more of a negative consequence. Unfortunately, they didn't assess ICOPE, but that was sort of a hypothesis that maybe all this pain fluctuation, it's unpredictable, you can't manage your activities, whereas even if you have high persistent pain, it's kind of stable and you can manage your activities.
Yeah,
Cheryl, I see you've still got your hand up. Oh, sorry, go ahead, Tim, if there's something you want to add to that.
No, I was just going to build and just kind of pointing out that as being a key piece around the threat value of pain. So that predictability or controllability would be a big part of how threatening is it, how much do I know about it, how much can I control it, which would play into kind of fear and maybe a tendency to feel helpless or not related to pain.
Yeah, great point. Cheryl, go ahead.
Okay, great. Thank you. Thank you very much, everybody, for your comments. This is just great. And I don't know if it gives us a better idea of where to go. We're really, we're trying to sort through all of these different metrics. But one of the things is going back to my first comment related to sort of pain, all the different components of pain. And in one of the studies that we've just completed, and Carrie was involved with this study as well at our university, was looking at sort of a response to a particular walking load. And we looked at pain intensity changes. We looked at WOMAC scores at baseline, as well as pain catastrophizing scores. And then we did the pain sensitization pre-post, as well as the pain intensity pre-post. And it was really interesting. It goes with what Lisa was sort of saying, was the group that actually increased pain didn't really have a higher pain catastrophizing score. So, but they did have lower pain pressure threshold scores. So they had higher sensitization to begin with. And that group was the group that had an increase in pain intensity. So what we were trying to do was we were trying to get at different components of pain by taking those different measures. How is it affecting daily life? And we didn't use the ICOP, which I think is also a very good measure as well. But I'm just wondering, like, from the pain researchers, if you were trying to capture the key components of pain in osteoarthritis, and I'm not saying we have to say specific measures, but what specific components should we be trying to at least ensure we're capturing as a minimum standard? And secondly, whether I know that Mick Sullivan has done a lot of work on pain behaviors in low back pain, and also did some work with looking at functional movements and how that can give us some sort of sense of an objective sense of if someone is experiencing pain, and if there's anything that you would know on that as well.
Lisa, do you want to jump in, or?
Yeah, I guess in terms of, measuring or using different constructs globally to measure, I would suggest that, you could kind of go along with the, as Monica had in her presentation there, the kind of Melzack's models, and kind of look at elements, the cognitive elements, the emotional elements, clearly the physiological elements, And then look to the literature to see where those, we know that there's associations, right? There depressive symptoms, pain catastrophizing. Fear avoidance has been something that's been far less studied in people with NEOA. There's not as much evidence for it. And certainly I think, self-efficacy and coping and things like that, we've been seeing more and more of that coming through in recent studies. So, that beyond the kind of typical pain intensity and looking at its qualities and whatnot. And then, of course, there's a large body of literature indicating the role of sensitization, both peripherally and centrally. So I think, from a research perspective, being able to implement QST is also very valuable.
Yeah, I would really agree with that. And just to kind of give an illustrative example, so Katherine was looking at the end of her presentation. Sorry, Dr. Boyer was looking at the end of her presentation. Changes in NRS pain intensity ratings over the course of a 6-minute walk. And we've done that same measurement and then also added catastrophic thoughts. So there are in vivo measures of pain catastrophizing. So as you mentioned, McSullivan had developed a 13-item scale, and there are kind of abbreviated versions of that are a little bit more suited to in the moment thoughts that kind of go through your head. And we've looked at that in relation to like a 6-minute walk task and found that actually in our sample of folks that have complex pain, mainly involved in the back, but that has a unique predictive value. So kind of catastrophic thoughts that are associated with movement has kind of unique predictive value related to that. So it's just, I just wanted to hold that up as a little bit of an example of the added value of not just looking at that intensity measure or sensory measure, but kind of bringing in specifically like the thought and feeling aspect of pain is something that I'd really recommend. I can also.
So we did the pain catastrophizing at the beginning, but what you're saying is actually also do it like a pre-post.
If you want, yeah. So if you want to, it's so it wasn't pre-post, but so in this, I can I'll try to dig up the reference as we're talking. Yeah. Share it with you, but it was my PhD student Arthur Vosnesky-Vu, who's the lead author on it. And so we did use a regular pain catastrophizing scale, but then in addition to that, we looked at kind of these different reactions, and the way that we framed it were these biopsychosocial reactions to movement. So we looked at intensity ratings of pain, we looked at the sensory aspects related to pressure pain threshold, and then we also looked at catastrophic thoughts. It wasn't pre-post because it wasn't, we were just interested in the catastrophic thoughts that were occurring during, so we just looked at it afterwards.
Okay.
However, in the regression model that we ran, we were controlling for the full questionnaire of the pain catastrophizing scale. So the upshot of that is that there was unique predictive value that was coming out of looking at these thoughts that were coming into people's minds during the physical activity, which in my mind, if you're predicting something like disability, like that makes good sense. And again, just trying to get closer to that clinical phenomenon, clinical experience that people are happening in their daily life, as much as possible, trying to bring that into the laboratory would be an interesting model, I think, to look at. So you're doing a movement and recognizing that the way that people react to that in relation to pain would have biopsychosocial components to it. So looking at their reactions from a pain intensity, but then also looking at it from a sensory or psychological standpoint as well is interesting. Can I swing back though to another part of the question, if that's okay? Just around objective measures of pain, and I would kind of really encourage folks to kind of steer away from thinking about using kind of objective measures as proxies or kind of more important than self-report measures of pain. I think we've seen that in other kind of lines of research like back pain and related to things like Waddell's signs, and it really doesn't kind of have much added value, I think, from a predictive standpoint or from a clinical standpoint, and it also has some real potential for harm, I think as well, in relation to stigma and kind of judgments around folks who are living with pain. So I, you know, that's not to say that it's not important to look at pain behaviors and things that can be looked at objectively, but I just would not hold them up as like a proxy or surrogate, or as somehow some replacement for a self-report measure, is how I would be inclined to think about it. And there was a lot of debate in the pain literature, mainly around fMRI research and how that should be used. But it seems to be, you know, recently that there's kind of renewed consensus around the idea that, you know, as limiting as it is, our best way of figuring out if somebody's in pain is to ask them, basically.
Great. I'm cognizant of time. We've got 3 minutes left. I'm going to see if I can try to get Hayden's question in. But before we do that, just I know Ryan Power, who is the network coordinator for the MSK Rehab Network, has a brief announcement that he wants to put out just before people start dropping off.
Sure, thanks, Michael. I'll just very quickly share just a two-slide little slideshow here. I just wanted to first off just thank everybody for joining today. Thanks so much to, of course, Dr. Hunt for a large part of the organization with this, all the speakers, and everyone in GaitNet, and everyone attending. I just want to say thank you. This has been really valuable so far, and I won't take up too much of your time, but I just wanted to pop in and just give a really quick announcement from the Canadian MSK Rehab Research Network. We're talking along the lines of, you know, collaboration and you know, potential multi-site studies coming up. And so I thought this would be pertinent today. So we actually have annually the Rehab Network hosts a funding competition for our network members. Seed funding is one of the major kind of annual priorities of the Rehab Network. And although our annual budget is relatively modest, our goal is to fund a diverse range of rehab projects and MSK research projects that align with current priorities. And so this is kind of a quick sneak peek because the official announcement will be going up tomorrow, but I did want to share with everybody, we will be launching our next grant competition tomorrow, December 1st. And this next round of funding will be focused on feasibility pilot studies intended to lead to multi-center RCTs. So I do think there's some good applicability to what we're talking about today. We'll have up to 6 grants available. We're hosting grants at up to $25,000 per grant. Again, I'll be putting out the official call and publishing it tomorrow, but everyone online today gets a little sneak peek at this. And the competition will run through the spring with an anticipated funding start of early summer of next year. So I'll be posting the full details on our website, which I've got on the screen here. I'll also post in the chat box quickly. So keep an eye on our website for updates. And if you're a network member, you'll receive the emails from our distribution list. If you're not yet a member, we certainly encourage you to join. So we welcome membership from anyone practicing research or clinicians, trainees, patient partners, industry reps, anyone actively involved in rehab research. We are more than happy to grow our network. So you can always send me an email at rehabnet@uwo.ca if you want some more information. Yeah, we'd be happy to have more people join. And if you have any questions about this upcoming opportunity, please let me know. But I don't want to take up any more time today. I just wanted to give this a little announcement for everybody. And thank you again to all the speakers today and to the organizers for setting this up. And of course, thanks to everyone for attending as well.
Great. Thanks very much, Ryan. And thank you to you, of course, for all of the behind the scenes organization bringing this together, and the whole Rehab Network as a whole. So I'm going to officially close it now. I'm happy to stick around and discuss. I mean, that's part of the goal of today was to generate discussion. A huge thank you to our presenters today, Drs. Maly and Boyer, and then of course our panelists who have joined, Dr. Wideman, Dr. Carlesso, and Dr. Neogi. Really great conversation. I hope that people didn't expect to come out of this 2-hour session thinking that we're going to save the world and cure OA and whatnot. I mean, that wasn't going to happen. But I think it has shown that there is clearly interest in this. And as I mentioned at the start, you know, one of the things that we're trying to do is, as part of GaitNet, is not only to build the collaborative research, but to provide a platform and provide a mechanism for people to come together and have these types of conversations. So those of you who were there in May, we talked a little bit more about the nitty-gritty biomechanics. Today was obviously pain and biomechanics. Love to hear people's thoughts in terms of what we might want our next one to be. You know, I think the first two have been very successful. So I think we want to try to keep that momentum going. It's not going to be a monthly thing. It might be, you know, every 3 to 4 months. But as I said, love to hear what people want and what people are interested to discuss. What are the big questions moving forward? So again, thanks very much to the panel and the presenters. Thanks everyone for attending. If you want to stick around, we can have kind of continue this informal discussion. Otherwise, if you've got other meetings or if you need to eat or something, feel free to drop off now. Thanks again, everyone. Much appreciated.
Thank you, Michael.
I've got to run, so I'm going to sign off as well. But thank you, everybody.
No worries. Thanks,
really
Tim.
wonderful. It was great to participate. Thanks.
Bye.